Hi, I'm Ingeborg Harvardson, leader of Women in Global Health Norway. It is my pleasure to open this first annual conference of our national chapter spanning over 2 days. Today's sessions will evolve around the inclusion of women in global health during the pandemic and various career pathways in global health. Friday, you can join the discussion around safety concerns for frontline healthcare workers and dive into some of the challenges for women in their global health careers. It is my duty to tell you to please respect our house rules. Cameras and microphones should remain off. You can post questions in our chat, and we will record the conference. Now, I'm pleased to introduce you to our two very esteemed keynote speakers, the co-founder of Women in Global Health Norway and its founding director, Professor Andrea Winkler, followed by the executive director of the Women in Global Health Global, Dr. Rupa Dutt. Warm welcome.
A very warm welcome from me as well, and I'm very, very happy to be here with you today. I've had actually the privilege to be part of the Women in Global Health movement for quite some time. To be more precise, since January 2017, when Women in Global Health Germany was launched in Berlin by Sabine Ludwig and Ilona Kickbusch. And it was then that Ilona quite spontaneously asked me whether we wanted to catch the next ball and create a chapter, Women in Global Health Norway. And we surely did, Ingeborg and I together. We founded Women in Global Health Norway, which was launched in 2018, late 2018. And ever since, the Women in Global Health Norway has been developing and thriving alongside an ever-growing and fast-growing Women in Global Health movement, and Rupa will tell you more about this. So at the moment, membership is around or even above 300 for Women in Global Health Norway, which is great because we started off with 20-30 originally. And I'm also very proud to say that Ingeborg, as the new leader of Women in Global Health Norway, has established, together with her team, of course, and advisors, counselors, a great strategy, 2021 to 2026, of Women in Global Health Norway, where the overall objective of gender parity in global health leadership is well anchored and also well pronounced. The whole Women in Global Health Norway is embedded in a structure that consists, of course, of the director, which is Ingeborg Harvardson, the secretariat, which is based at the Center for Global Health at the University of Oslo, led by Jeanette Magnus, and then an advisory group, special counselors, and also task forces, like a conference task force for this conference now, and also a COVID-19 task force. And both of those task forces have been crucial in the organization of this event. So Women in Global Health Norway also exchanges, of course, regularly with the other national chapters and the overall European chapter, and maintains very close ties with Women in Global Health Global, which is our mother chapter, and of which Rupa will tell you, I'm sure she will tell you more about in a minute. Before we get to that, I would like to introduce you to the 5 asks around gender equality and global health security, which was actually created by the global Women in Global Health movement and launched at the very beginning of the pandemic. So thank you, Gabrielle, you have brought it on. You can all see the slide. So there are 5 asks. Very briefly, you can of course read them, but I summarize them for you quickly. So the first one is include women in global health security decision-making and of course the discourse. And it's a disgrace to see that again in the public arena, but also in academia publishing, there is a large preponderance of men, and women are yet again left behind. Just to quote one area of this pandemic and what it demonstrates again, and that will be also today's topic. Then the topic of Friday will be that provide healthcare workers, and of course most of them, the frontline workers, are women. So supply them with decent working conditions, safe and decent working conditions. Number 3 is recognize the value of women's unpaid care work and channel it into the main system. Number 4 is to adopt a gender transformative approach to health security data analysis and response management. And number 5 is about finances, so that of course all these great movements can be supported. So with that, and without further ado, I would like to hand over to Rupa Dutt, who is the Executive Director of Women in Global Health Global. Rupa, it's always a pleasure to be together with you on panels, and we are looking forward to hearing what you want to share with us. Welcome, Rupa.
Great. Thank you so much, Andrea, for such a wonderful welcome. And I'm so excited to join all of you, especially as the community of Women in Global Health Norway has been very active and a great example of what it really means to mobilize and activate a global movement. So to kick us off, I wanted to share some really exciting news that, particularly for us this past year, we have grown immensely. It's the first year Women in Global Health has actually have core staff and a capacity building grant, and we have seen our movement grow from being around 10 chapters to almost 24 chapters in the pipeline. So for us, that is a really exciting news, because it means that the community is vibrant and that the movement is growing, and that all of you really have an opportunity to connect and collaborate with each other and really shape the global agenda. As we know, we are facing unprecedented times. We know that viruses don't discriminate borders, and they are affecting populations around the world, people every day, in unequal ways, especially women. And so one of the things that we as the global movement decided to do is, in the early aspects of the pandemic, was really mobilize. And what I mean by mobilize is that we noticed that there were too many conversations happening about the pandemic and COVID-19 that were gender blind. And we know the gender implications are vast. They have a ripple effect. And we know that gender equality really should be everyone's business, yet it continues to be seen as a special interest and continues to be left off the table. And so in March, we launched a campaign called COVID 50/50, a gender responsive approach to global health security. And that campaign, as Andrea just highlighted, has 5 asks, and those 5 asks have become pillars that our chapters and our partners and supporters and allies have been using throughout the last couple of months to really ensure that we make progress and we make sure that the pandemic no longer continues to be gender blind. Some of the ways that we've been able to do that collectively, the first has really been bringing visibility to women who are leading in global health security. We launched a list called Operation 50/50, which has now over 100 women from 40 plus countries around the world that are known to be health experts in disease outbreaks, in health security, also including frontline perspectives. And we're so excited that that list has been picked up and used, especially by media, including Euronews is one particular example, but we have been contacted by many mainstream media channels, and we've known that the women featured in this list have been invited for interviews, have been invited for working groups. And that is one simple way that we were able to move quickly, respond to a situation where women were not being represented equally, and really just make a quick impact. But of course, we know work doesn't stop there. Another really key milestone for us was around the World Health Assembly. It was the first time in history that the World Health Assembly was taking place virtually. And as many of you that are joining today that are engaged with the World Health Organization or engaged with the government, or various governments, or active multi-stakeholder actor in this space, you will know that there was a historic resolution passed on COVID-19. And one of the things that we can say very proudly is that Women in Global Health, through our chapters and our supporters, really mobilized to ensure that that particular COVID-19 resolution had strong language on gender, especially around making sure that women were included in decision-making, were included in all aspects of the COVID-19 response. 3 of our 5 asks were actually featured, and we're really delighted that, the governments that supported this behind the scenes, we really appreciate that leadership. And the third most exciting thing that's happened, and one that we are going to see the momentum continuing on with our COVID 50/50 campaign is really around our very first summit that Women in Global Health hosted was around the theme of women in global health in global health security. Which we were able to welcome the president of Ethiopia, Sahil, and she shared the narrative of how powerful it is to have women's leadership, especially in decision making. And at this particular summit, not only did we have conversations, but one of the core exciting things about the Women in Global Health movement is we are action oriented, and we were able to garner commitments from over 40 different organizations, which includes 7 government pledges. And I have to say a special thanks to the leadership here in Norway, especially Ingeborg, for facilitating the connection with the government of Norway. And we received a commitment from Norway, particularly that they would be more gender responsive when it comes to the ACT pillar that they are responsible for. So we were very, very thrilled to see that not only were we bringing visibility to the issues surrounding women's leadership and women's representation, we have also seen progress being made on how to make sure that this pandemic response is gender responsive. And really for us, the catalytic moment was the summit. And we still know that there's much more work to be done. What I really challenge all of you to do is really think about how can you participate in the COVID 50/50 campaign, especially through your chapter, and how can you bring the leadership that you have, each individual and each organization that you represent can really leverage their influence to make sure that we build back better. Women in Global Health is calling for a new social contract where women are represented in equal leadership roles in global health, but also more importantly, that they have decent and safe work conditions and they are compensated equally for the work that they do. And this social contract is not something new that we're asking. These are commitments that governments have made to us for a very long time. It is about acting on them when there is an opportunity now to build back better. So I'm really thrilled to say that the global movement is thriving. Our chapters are creating task teams. They're putting on power dialogues, a special recognition to India that's had many special series focusing on creating a platform for the women that are the least represented. So the invisible women, the frontline community health workers that are not represented. Our Somalia chapter has been engaging with closing the gender data gap. They worked with their ministry early on to start advocating and working on structures, particularly to see how the sex and gender data gap could be closed. As we know, in COVID-19, the first round of data that was being collected on infections was gender blind, and sex disaggregation was quite limited. We're up to about a little over 50 countries globally, but out of 193, there's a lot of work to be done on that front. And I'd like to also recognize our volunteers that have been providing countless hours to really fill a lot of the key essential advocacy and data gaps. We most recently released a paper in the BMJ, British Medical Journal, which shows the data that when you take a look at COVID-19 task teams from over 87 countries and 150 task teams. Many of them are decision-making bodies and advisory bodies. When you look at the ratio of how many truly have gender parity, only 3.5% have truly gender parity, and 85% of these task teams are majority men. This particular piece of paper was picked up by CNN News and has been widely circulated. And we have also been in discussions with the World Health Organization. And as part of our civil society engagement with the World Health Organization, we have been able to get a commitment from WHO that they will be starting a COVID-19 and gender working group, which will be a multi-stakeholder working group, including especially civil society supporting and making sure some of these issues are no longer forgotten about. So we're very excited about the year that we've had, but we know there's a lot more to do. And again, my call to action to all of you is that please continue to be active in the movement. Please continue to engage with your chapter, but also think about how you can connect and collaborate with the entire network, because there's a lot of work to be done. And again, thank you for all of your leadership, and a special thanks to the team at WGH Norway for putting this summit on.
Well, thanks so much, Rupa. I mean, it's always so insightful. And I just wonder, it's just a couple of years that you have given us, but it sounds to me as if it was 20 years of work. And I also have to say that you work as a doctor, as an MD, and you do this on top of it, or alongside. So again, always very impressive, Rupa, and of course your team. And I'm gonna come to one particular person of your team very soon, Sarah Hillware. But before that, I would like to welcome our participants, because we are almost now 90, so almost 100. So we have just crossed the 90 border, the 90 limit. And my name, I'm just going to moderate the next session. We're now moving into session 1. My name is Andrea Winkler, for those who came late, co-founder of Women in Global Health Norway and also founding director. And I will now introduce you to the speakers. Our topic, again, for those who were not able to join from the beginning, women are, make up 70% of the global health workforce and are underrepresented in COVID-19 decision-making, leadership, media commentaries, but beyond, also academic decision-making, private industry, you name it. So we will focus around the first ask of the 5 asks that I just shown you. And we will now start. I will start introducing our 3 panelists. Each of the panelists then will take around 7 minutes to answer according to their likings, with or without PowerPoint, the questions that we have prepared together. And then we're going to open for questions from the audience. So just bear with me for a short introduction, one after the other, from our esteemed speakers. So I will start with Sarah Hillware. She is a colleague of Rupa, who we just heard. She's the Deputy Director of Women in Global Health. Global, and also Sarah, you are an award-winning social entrepreneur, global health strategist and advocate for girls and women. And throughout your quite condensed and powerful career, but rather short, I have to say, in terms of years, you have worked at the intersection of project operation and stakeholder engagement to drive global action forward, and also to engage with national policy reforms across the Sustainable Development Goals. You have quite a bit of work experience, WHO, World Food Programme, UNHCR, and PAHO and the PAHO Foundation. I will then move to Benton Mickelson, who is now working in Geneva, but she is Norwegian and has, of course, very close ties still with Norway. Bente, pleasure to have you. You are the Director of the Non-Communicable Diseases in the Division of Universal Health Coverage / Communicable Non-Communicable Diseases at the WHO headquarters in Geneva. You're also you're an MD, you're a trained gynecologist and obstetrician, and you hold a master's degree in health administration and management from the University of Oslo. You're currently focusing on achieving the SDGs through the reduction of premature death from NCDs, non-communicable diseases, in the context of the WHO General Program of Work, but also working across sectors. And this is something that is really important. So the multi-stakeholder involvement within and beyond the health sector. And you use innovation as your tool, implementation of research, health literacy, and the new technologies. And most likely I have missed quite a few things. So welcome again, Sarah and Bente. I'm now going to move to Anne Berg. Last but not least, Anne is a very dear colleague from Norway and has accompanied us for a long time. She also sits on the board of the Center for Global Health and has also been very instrumental, I hear from Ingeborg, for the development of the strategy for women in global health Norway. So upfront, a very big thank you to you, Anne. You have a varied background from international collaboration, development, and public health, including working 10 years for the Red Cross and the Red Crescent movement in Oslo and Geneva. And since 2017, you held positions in global health and also in the area of migration at the Norwegian Institute of Public Health, where you currently lead the global health cluster. And also a very warm welcome to you, Anne. We're now gonna dive right into the first question. And again, I'm using the same sequence. Sarah, I'm turning to you. And we all know that the past half year, or not just half year now, it's almost 8 months, has been really very, very exceptional. Our communities have focused just on one threat, and it's amazing what we have been able to leverage in different sectors and fields, let alone academia. We never had so many publications on one single topic. I'm just mentioning this because this is my field. So COVID-19 is permeating us. But unfortunately, it has pushed back other significant global health challenges. And we all know it's in the press, and we're also researching on it. Malaria, vaccination programs, mother and child health, non-communicable diseases, to name just a few. The pandemic has also exacerbated health disparities that have been well covered up, or social and gender inequalities. And Sarah, reflecting on this present crisis, can you give us a glimpse into how Women in Global Health Global, so the overall Women in Global Health movement, responds to that global crisis? Sarah, over to you. Thank you.
Great, thank you. So we all heard Dr. Rupa speak about what we're doing, and so I'll talk a little bit about the why. So we launched 5 asks for gender responsive global health security. And of course, the first one is focused on leadership, but the other asks are focused secondly on safe and decent working conditions for women health workers, who we know are 70% of the health workforce. The third is around unpaid work, so ensuring that women are paid fairly and compensated for the work that they do, especially in health. And we know that community health workers, especially, who are in many contexts, 90% women, are oftentimes unpaid. And so the third ask, what we're really doing is focusing on gender responsive health systems. And in particular, we're focused on gender disaggregated data. And the fifth ask is about women's movement. So mobilizing movements at the country level and at the global level to really support these other asks. And so, you know, what I really want to focus on again is the why and the how. And so why are we doing this? Because COVID-19 is not an equalizer. We heard many at the beginning of the pandemic talk about COVID-19 being this great equalizer, but in fact, it's exposing the dark truth of deep social, economic, and political inequities that are actually driving ill health and pandemic within and between countries. So we've seen that viruses don't respect national borders. And we've seen that the rich are able to protect themselves and will be the first to access potentially vaccines. But no one is immune. So none of us will be safe until the virus is eradicated everywhere. And of course, when we don't have universal health coverage, we don't have gender responsive health systems, we're seeing the most marginalized groups left even further behind. So data from the US in particular shows a higher mortality from COVID-19 among minorities, and the same in the UK. And the primary causes are long-standing structural, social, economic, and health disparities, with lower status social groups having more exposure to infection in lower paid and frontline jobs, and also overcrowded housing, poor underlying health status in the USA, and less likelihood of health insurance. And we know that being a woman actually exacerbates even these inequities. And so the why is really about how do we address the inequities, but do it in a way that's gender transformative. And what does that mean for women's leadership? So the reason why we need women in leadership roles is because women in particular are proven and have a track record of really prioritizing the most marginalized. And when we prioritize the most marginalized, then we actually have better outcomes for everyone. And what we're saying is not that women are born with an empathetic gene, or not that women necessarily are intrinsically more fair or more collaborative, but that they do employ these traits. And so what we're asking is for gender transformative leadership. We're asking for gender parity, and even moving beyond parity, to ensure that we have a response that's very much embodying these values that lead to global health, better global health outcomes. Thanks.
Sorry, I had to unmute myself. So thanks a lot, Sarah. I have a second one for you. You have also created as also other country chapters, but you have also created in Women in Global Health Global a task force on COVID-19. So I was just curious, how are you addressing the gender imbalance in the response task force on COVID-19? Could you just give us a couple of examples? That would be really helpful. Thank you.
Yeah, absolutely. And Rupa mentioned our Operation 50/50 list. And so I'll just give a little bit of background on that. So what we were hearing, first of all, when it was towards the beginning of the pandemic, we saw that there were only 3 women on the U.S. National Task Force for COVID-19. We also saw that the WHO Task Force was majority men. And so what we were hearing is that, where are the women? We can't find the women. And so we launched this Operation 50/50 list in an effort to really show that the women are there, that they are on the front lines, that they are in policy and decision-making roles, but they're not the ones who are visible, and they're not the ones who are oftentimes in power. And so what we aim to do is really crowdsource this list of global health security experts, so that they would be the first to be called on when it comes to public dialogue and discourse, and also when it came to countries at the national levels and also at the global levels, compiling their task teams for COVID-19. And so this is an open source list. We now have over 100 names of women all over the world. It's geographically diverse, and anyone can contribute to this list or nominate someone, which of course then goes through a vetting process. But we're hoping that this list will become a list that will then be able to quell the excuses of we can't find the women, right? So that's one thing that we're doing. The media has actually picked up this list, and they've interviewed several of the folks on it. And those women in particular are ones who have expertise that we cannot afford to ignore. The second thing that we're really doing is we are working with organizations, especially global health organizations and governments, to really ensure that we have a gender balanced approach, and really educating them on why it matters. So through our Women in Global Health Security Summit, we actually released a report about rebalancing the unequal social contract for women. And what this report is why it matters for us to have a gender parity on task forces and gender equal representation. And so when we actually bring this data to our partners, to governments, then they're actually able to very readily able to make the case about why it's important for us to have gender parity, and also why it matters, not only as window dressing, but really for economic outcomes, and also for better health outcomes. So it's really critical that we continue to collect that data, we continue to build that evidence base, and then really get it in front of the right stakeholders who have the power to make those decisions. So those are just 2 of the things that we're doing right now.
Well, super, Sarah. Thanks for the concrete examples. And again, so impressive. As I just said with Rupert, to me, it doesn't sound like 6 or 7 months. So what you're covering sounds like years of work. So extremely prolific and well thought through work. Thanks, Sarah Hilwer, to join us today. And please stay online for the next rounds, and hopefully also for the other session. I'm now going to come to Bente. Bente, it's a pleasure to have you with us. Sorry, Benton Mickelson from WHO. And Bente, you have really shown great leadership by bringing the NCDs, the non-communicable diseases, high on the agenda. And that, of course, together with your various teams. And as an example, I just want to give the involvement in the inclusion of the NCD strategy. And we have been together in this. The Center for Global Health was also there last year, end of 2019, into the Norwegian development agenda. So an NCD strategy into a into a development agenda, and that is the first time that this has really happened through a country, nationally, through a ministry. And this is also something for what Norway has been praised and received a very, knowledgeable, a very well received prize, which I just read it now from my script here, which is the United Nations Interagency Task Force on the Prevention and Control of Non-Communicable Disease Award. So it's a big UN award. It just shows how well this action is appreciated, and you have been you've played a major part in this. So COVID-19 has, of course, exposed deep inequities, and access to healthcare has been jeopardized at many different levels. And we would like to hear from you today, Bente, at the level of chronic diseases. So can you enlighten us whether in the context of chronic diseases, non-communicable diseases, there has also been a gender divide? Most likely, yes. And if so, in which way? This is your first question. Welcome, Bente.
Thank you very much. I don't know if you can see my slides. Can you, Andrea?
We see your slides.
Can you see my slides? Yeah, very good. So I have chosen to use some slides because I want to triangulate between women leadership, the COVID-19, but also the non-communicable diseases, because we need to know what to fight to be efficient. That's sort of my buzzwords here. And I don't know, and I hope that you realize that the world's biggest killer, which is the non-communicable diseases, meaning heart, lung cancer and diabetes, who is yearly killing 42 million people, actually has been the most sort of suffering and most impacted by COVID-19. And we realized this fully already in May, where female healthcare workers, because those are the most frequent, but also people living with NCD were telling us that we are not anymore getting our medicines, we are not able to access our hospitals. So Richard Horton said not so long ago that we have a syndemic, we have a pandemic of the COVID, but we have also epidemic of NCDs, and this is really a deadly interplay, as I call it. And Dr. Wren from also the World Health Organization says that it is impossible to end COVID-19 pandemic without bringing hypertension, diabetes, and cancer care to all who need it. And I'm saying this today because we cannot focus on a virus. We have to focus on the whole health system. So what we have seen is that there has been people living with NCD are the one who has been severely ill, hospitalized, and also dying. These are the people who have been undiagnosed, untreated, and unprotected. What has this to do with women? And I still remember visiting the main office of UN Women in New York, and I were asking the executive director, what do you do about NCDs? And she said, well, I thought you were taking care of the NCDs. And then I said, are you aware that 6.2 million women are actually dying before the age of 70 every year? And she said, you must be kidding. If this was the case, I should know. And she was, of course, a champion of maternal and child health and family care. So I think it's also about awareness building. So let's not get tunnel vision, only focusing on what people are trying and countries are trying to defeat today, namely the COVID-19. Because we have seen, in addition to that, the healthcare workers play a disproportionate role of COVID-19 response, we also see that the implications of COVID-19 are different in men and women. We know that this is exacerbating the burden of the unpaid care work on women and girls, as already mentioned by some of the other speakers, and that the economic impact caused by COVID will hit women harder than men. We also know that we have an increase in domestic violence, and also that we see that the resources that goes traditionally to services that women need are diverted while we are focusing on COVID. So, and especially I think it's important that we stand up, and again, coming back to what do we see in and during the pandemic is like an X-ray. It sort of shows the fragility of the health system. And I'm sure that you remember when it was an evaluation of Abella, one of the main take-home messages is that there is not possible to be prepared and to actually have social security without focusing on the chronic diseases. And they mentioned at that time, and we will see this again, that the people who are dying during COVID is the people with the chronic diseases. So I also want to say that we need to be very sure that we have access to sexual and reproductive health care in this pandemic. And we know that before the pandemic, 810 women died from preventable causes. And we see, of course, many of the other figures. So we need to have data, we need to follow, we need to focus, of course, to defeat any pandemic. But even, I think at this stage, what we need to do is really to build back better and in a different way, as already Ropa was saying. So you have a question to me, what are we doing? I don't know if you want me to continue to the second question, maybe.
Yeah, so the
That's
second
okay for you.
question. Yeah, Bente, thanks a lot. So the second question, I think most likely this has already partially been answered, but it would be that COVID-19 has exposed all these gender inequity at various levels of the healthcare system. So not coming now from the non-communicable diseases alone, but also reflecting on the healthcare system. And could you elaborate or letting us know what is in the pipeline, how WHO will lead a transformation process that ensures that those gender inequities gaps are closed. So Rupa has already alluded to a task force that is going to be formed, but maybe you can continue on that.
Yeah, so again, you know, I agree with you, it's about healthcare, but then we have to be very carefully addressing what is the global burden of diseases. So when we speak about healthcare, we very often make it very cloudy. So that's why I know that maybe I'm boring you with the non-communicable diseases, but this is the major part of the healthcare system. So I think the support we need to do to bring equity and equitable solutions, and with a specific focus on gender, has to be in business as usual and business as unusual. But you were asking me what is happening, and we have heard already about the task force. But I think we have the opportunity to utilize this very, very challenging time to support and advocate governments for implementing intervention that can control NCD as the biggest part of the diseases, but of course all part of the diseases in a fair and equitable way. So we also have addressed in WHO as part of this endeavor also the youths, because the youths has been a kind of victims of this pandemic in a different way, because in the beginning they were forgotten. And then very many youth activists, which you will be appreciative to know is women, has advocated for Youth Advisory Council. So this is important. And then it is the lived experiences of women. And we are more and more talking about having the people living with around the table. We also continue to work on the strengthening of women's leadership. And thank you so much for exposing also organizations like WHO. This is needed. We need our organizations as watchdogs. And we need disaggregated data. We need it during COVID, but we need it always. And I think you will see that WHO is also trying to immediately translate many of these experiences into boosting into some of the countries. And also, as was mentioned here, it's called a task force, but also the working group. So one thing is the UN organizations, but what I think we need to do as UN is to really translate this immediately into what can governments do. And I won't tire you with a lot of slides, but I just want to show these two. And I think the way we need to work is to really work through the gender lens. There is nothing to be shy about. It's important, and it's important both for men and for women. So we need the multi-sectoral analysis. We need to have gendered impact and invest, as I said, in data. We have to support the NGOs. And as you probably know, many places in the world, we don't have governmental support for NGOs. And this is important for human rights and for gender. And also to ask and hold governments accountable for being gender responsive. And then, of course, the gender-based violence, the protection of the services, and especially being gender-focused, even when we analyze what should and what is part of the universal health coverage. And then prioritize women and institutionalize. So this is sort of and I had huge pleasure in preparing for today's speak, and so happy to be here. Thank you.
Thanks a lot, Bente. It's always a pleasure to listen to you. And as you said, well, thanks for this spotlight on non-communicable diseases. But as you said, talking about healthcare system, the majority is actually non-communicable diseases. And we have another 70% number. We all know that the burden of non-communicable diseases is beyond 70%. And we also have this magic 70% of women in the health workforce. And that should be my transition to the next speaker, which is dear Anne Berg. And Anne, your first question would be that, again, this magic 70%. So globally, women are 70% of the global health workforce, but underrepresented in COVID-19 decision-making leaderships. And you have heard this, this sentence before already. So you are with the Norwegian Institute of Public Health. So what is the picture in public health institutions, and how do you see the COVID-19 impact on women in the global health workforce from your perspective, Anne? The floor is yours.
Thank you, Andrea. It's always a bit of a challenge to be last. And again, I can sort of summarize things that I think is important. So there's pros and cons. So first, maybe a couple of reflections on the first part of your questions, being on the representation of women. I think we sort of tend to think that, at least in Norway, we're very sort of, the gender equalities come very far. So I looked up at the Statistical Bureau to see what is it actually like when it comes to leadership positions in this country. And it shows actually that only 1 out of 3 leaders are a woman, and 1 out of 4 is in the top leadership. So even in our own country, I think we still see that we're not really there yet. We have still a way to go. And I think Bente, you said your sort of thread going through was about we need to know to be effective. And I think mine is that, yes, and we still have a way to go on the gender equality side. And I think when it comes to COVID-19 as well, already in April, the UN Women's Rights Committee issued a call on governments and multilateral institutions to ensure women's equal representations in formulating response to COVID-19 and strategies to recover from the crisis. So I think also then that this makes it even more concerning when Dr. Bernadette mentioned earlier that in the study that she mentioned, where they looked at the different task forces, that 85% were actually having a majority of men. So there is clearly some work that we still have to do. And I think in crisis situations, to ensure the gender equality and the gender parity in leadership, we're not really there yet. And I think that it also goes for the public health institutions on a global level, even though in Norway, we have a very fair balance in the leadership. I mean, we have a female director, we have a female deputy director, we have a female leader of the outbreak response team to the COVID pandemic. We have also women in the senior management groups. So I think in our own institution, that's been taken to a fairly good level. But I think in the global scene, I just went through who attended the last annual meeting of the National Public Health Institute's Assembly, which was in December, and I thought roughly a third is women there. So I think that also another thing that is bringing this to an interesting point now is that public health institutions in times of crisis and in times of pandemics play a very critical and key role. And also, like Benton mentioned, the institutes are gathering data. They have a systems approach where they can see more than one topic at the same time. And we need to combine and use that knowledge. And I think also we saw after SARS and Ebola that as the public health institutions become more central in the response and more known in their societies, countries also tend to create new ones. So in 2004, after the SARS, and in 2014, after Ebola, several countries actually set up public health institutions. So in that, this is the time, this is a very sort of good time for women in global health also to pursue that new institutions get a gender equity into their, and gender parity into their leaderships. So this maybe then bring me on to the second part of your question, Andrea, which I think a lot has been said about when it comes to the question on COVID-19 and the global health workforce. 70%, yes, and we see, I looked up at the UN Women's reports, and it shows that of confirmed cases among women health workers, they are certainly hardest hit, with confirmed cases of 77% in Spain, 74 in Germany, 73 in Germany, and 74% of the confirmed cases in the health workforce are women in Ireland. So yes, we see that, and I think it is a call of concern, but I also think that we need to take into the considerations that women in the global health workforce are also exposed to other difficulties. There was another recent study that looked at women and COVID-19, for instance, gave an example from Sri Lanka where women health workers faced really the families and social networks shying away from them simply because of fear of being infected. So I think in that sense, we also have a set where we need to see that there's been a lot said now about women being more vulnerable, more exposed to then having lower education, being more at risk for ending in poverty, and so on and so forth. But I also think that we need to keep in mind that the global health workforce contains not only well-educated women as nurses and doctors, but also quite a few local village workers that do carry out the everyday work in their village as part of their local health system. And they're also exposed in a number of ways also when it comes to more of the financial risks, not only on the infectious side, but also for job loss, for also getting less remittances from other family members that might usually work in other parts of the world and send money home from businesses which now may be closed down. So there is a whole sort of range here of situations. So I think the IMF expectation is that extreme poverty will rise in 2021. We know women will be more exposed. And I think we really just need to use this opportunity to put the gender back on the agenda, because we can think that we have discussed this now for so many years and it is put out there very firmly. But I think now that we have a moment in time, a momentum in time, where we need to bring this back on the agenda. Because I think the COVID-19 will widen the gender gap, and it will also make the gender gaps that is going to stay with us for quite some time before women get back into the positions. Girls might lose out on education, and so on and so forth.
Well, thanks a lot, Anna. And you have already almost answered the second question that I had for you. You have explained to us that we have gender issues, of course, from grassroots level up to the top managing positions. And my last question, but please a very short answer to that one, because we're already in the Q&A time, but I think it's an important question to ask. What can women in global health do, or how, what can they do to promote women representation in global health governance? So, I mean, you quite rightly said grassroots level. I mean, the women are not even insured. They have less money for the family. They're exposed, etc. But governance in general, how can women in global health promote recruitment of women into global health governance?
Thank you, Andrea. I think when it comes to why it's important and what can be done, I think the Convention on the Elimination of All Forms of Discrimination Against Women was adopted by the UN General Assembly in 1979. That's more than 40 years ago. I think what we see now is a new generation. And maybe this new generation that is now part of the Women in Global Health will be much better placed to actually help close the gender gap than what was the situation back in 1979, because of social platforms, because of IT technology, because of communication ways that was not simply available back in time. So I think what can be done to make this a bit short is that the 5 asks, I think, are very good. It's put it firmly on the international agenda. I think also the network is a very important thing, because through the network, it's also possible to link up with human rights groups, to keep also use the human rights system to keep governments accountable, because this is really very firmly within what has been a commitment from governments for many years. So I think there is a room there to maneuver. And I think also in that sense that the 50-50 list that puts women in a position where through the network they can be exposed to be part of different groups, expert groups, task force and so on, is also a very important part, because I think we need to have the women that we know, we need to make them known. Because there isn't a given that people that works in Somalia is known in Geneva when the task force is set up. Somebody will have to make that connection. And I think through the network of Women in Global Health, that is a possibility. So yes, let's keep in mind that not all health workforce is highly educated and living in Europe. There is also village workers, and we need also to give the chance of people having an equal voice from different parts of the world. And that's why I think the chapters of Somalia and India are really great that the Women in Global Health managed to set up in such a way. Thank you.
Thank you, Anna. This is a very nice conclusion. The equal voices from women all around the world. And with that statement, I would like to start the Q&A session of our first National Norwegian Women in Global Health Conference. And thanks again to the esteemed speakers. Thanks a lot for sharing your insights from different perspectives. I think this has been really great, and also, I assume, quite a bit of food for thought for our audience. We are now around 100, most likely mainly women listening, and I can only select a couple of questions. So please forgive me if we cannot read out all your questions. But I'm just gonna start, and I have very nice ladies in the background, Joanne and Gabriella, who helped me filtering the questions. So I will just start with a question and see who then can take that question. What do you see the biggest opportunity, not challenge, we've talked lots about challenges now, but the biggest opportunity arising for women from the COVID-19 pandemic? Maybe I would like to Bente to go first, a quick statement, and then Sarah and Anne, very quick statements, because it's a general question.
Yes, thank you for the question. I think the most important is to really see the innovation going on in these difficult times. So we have seen task shifting, meaning that new operational models involving women. We have seen new ways of delivering health services, use of telemedicine. So I think look for the innovation in the pandemic and learn from that.
Excellent statement, and very short. Sarah, statement from your side, opportunities through the pandemic for women.
Great. So in terms of opportunities, I mean, it of course sounds a bit strange to refer to the pandemic as an opportunity, but in fact it is, because we are at a critical juncture where we can either take 10 steps forward or 10 steps back. in terms of gender equality. So we really do have an opportunity, as other speakers have mentioned, to build back better with women at the center and gender equality at the center. And so this is essentially a turning point for us in global health, where we can choose to either really embed gender equality in everything we do, or we can choose not to, and we can roll back the progress that's been made over a number of decades. And so, I really do implore governments, I implore global health organizations to really take a hard look at the way that we're working, and really put women front and center of decision making, and also all global health policies. And so this not only means having women in decision making roles in large organizations, but as another speaker mentioned, also really imploring the expertise from health workers who are at the community level, who are majority women, ensuring that their perspectives are front and center when it comes to building back better. And also the unpaid social workers as well that we see. So not just the community health workers, not just nurses and midwives, but also those who are doing work that is adjacent to the health sector, such as those caring for the elderly, caring for children, et cetera. So we really need to be able to design a whole of society approach that really looks concretely at what's actually being done, that's contributing to health, but may or may not be seen as part of the formal labor market. So we do really have an opportunity to bring those roles and to bring those women into the forefront that we did not before.
Excellent, very good. But now we need very, very short answers, because otherwise we will not be able to get to most of our questions. But extremely important what you just mentioned, Sarah, and absolutely correct too. As you said, I mean, of course it is a crisis, but every crisis has also its benefits in a way. And we have to work with those, and we have to build on those. And thank you for your insights again. Anne, what would you, I mean, you have told us a lot about what actually doesn't really work. So the challenges. So what would you see as opportunities for women? You actually have
very short, I think.
Sorry. Very crucial. Sorry to interfere again. And I think this is important. The infrastructure building at the moment. And that is a real opportunity to put women there, isn't it? I let you answer now, sorry.
Yes, I think that is an opportunity, because things will be built hopefully back better, and certainly built back in new ways. But I think what my take on your question would be is simply for women to use this opportunity to connect with new groups in new ways. Because now you have a totally different situation where you can connect across not only borders, but also across age groups. I mean, we would normally use opportunities like this to meet in person. That was very much more restrictive. Now we meet online. That means it's fairly open. So it's a chance to meet up with new groups in new ways. That would be my opportunity.
Thank you. This was short and sweet. Thanks a lot. Maybe I just stay with you, Anne. There's another question here that I'm reading in my chat, and that is, I think, a very, very clever question. We know that there is underdiagnosis of COVID-19 worldwide. Do we have any insights, and maybe through your work at the Public Health Institute, do we have any insights as to whether it is more underdiagnosed in women than in men, or even vice versa? Any ideas about this? Or any data around this? Anne? Oops, you have connection problems?
Sorry, yeah, okay.
Yes,
I don't think I'm the right person to answer that question, but I think what is important is that we can actually have built out systems, as you said before, so that we can have not only diagnosis, but also ensure that vaccination will be available to all groups in society. So I don't have data on to which extent on the global level that we have a fair grip of in the different countries. how many are actually infected or how many is being diagnosed.
It's most, thank you, and it's most likely also the access to testing, isn't it? Is access to testing, is there a divide? Can anyone, maybe Sarah or Bente, give us some insights very briefly? Do we have a divide in access to testing, a gender imbalance there? Do we know anything about this?
Actually, I can address that. Women in Global Health has been working with the Foundation for Innovative and New Diagnostics actually on a report on the gap in testing for women. And so we are seeing a divide in particular because not only of, within the healthcare sector itself, but also the gender imbalances that are occurring in the homes, right? So oftentimes women, what we're seeing is that, they'll have to, ask permission, to be able to see a healthcare provider. Sometimes they'll be the last to get tested, because, the male household members take priority. So there are many reasons that we see these gaps. Particularly in low and middle income countries. But we also see these gaps as well in high income countries where oftentimes gender, is of course correlated with poverty. So, those families who are already in poverty, women are oftentimes, at the sort of the other end of the disparity when it comes to testing as well.
Yeah. No, thank you, Sarah. I mean, exactly what one would actually imagine. And I'm sure there will be data at some stage, but it can only be assumed that there's a gender imbalance as well. Bente, would you like to add? I've got another question for you, actually.
Yeah.
Would you like to add to that?
Again, it's very important that the disruption of the health services during COVID is really impacting very uneven. So, this is about getting your blood pressure measured. People don't get it measured. Cancer is undiagnosed and untreated. For the family, it's very difficult many places to get hold of healthy food. So all the risk factors for getting ill is also driving people into disease and to poverty. So I think, again, we have to widen the scope. One thing is the testing. While we are waiting for the vaccine and for the test to be spread to everybody, people are suffering big time. So in 75% of the countries, the healthcare services is disrupted in 50 to 60% of the cases. So people are not getting their rehabilitation after lung diseases. And you see now that even the rehabilitation phase after having COVID is impacted. So again, I think if you want to do something about equity, given it between genders or in general, you have to look at the big picture. So this is, and I'm really trying to make this case because I can see that many things are so short-sighted. So this is, the pandemic gives us a fantastic opportunity to look at the inequity and very much lack of access to services, to medicines, and it's a big gender thing in there. So let's look at the big picture and utilize this opportunity to get it straight.
Thanks, Bente. Bente, I can't let you off the hook yet. I've got another question for you. It's a long question, and it says question for Bente from Catherine. I'm not sure whether you expected a question from Catherine, but I just boiled it down to basically she's concerned, and I fully share her concern about mental health. In times of the pandemic now, and I just try to boil it down. So basically, what strategies does WHO have in place or is currently putting in place to counter the mental health effects of COVID-19, especially in low resource settings? Can you tell us a couple of sentences about this, Bente?
So this is absolutely true. We have seen that the same disruption of health services is the same for mental health. So first of all, the prevention and the treatment and the control of mental health conditions is absolutely impacted. So we see the same 75% of the countries, 50-60% of the services is not available at this time. We have the same sort of situation with the medicines. So it's first and foremost, again, to focus on this. Then I would say that my colleague, Dr. Deborah Kestrel, with all her global leaders with her, has done a marvelous job. And that makes me, makes it possible for me to say that, you know, it has been so much disinformation during this pandemic. But there is one place to go, and that is on the WHO website, and especially on mental health. It is excellent materials. I think the playbook for children is now translated into something like 120 languages. So, of course, the big concern about mental health conditions directly sort of leading from the confinement and the situation by losing your relatives has been very, very much addressed. And I need to make one more point because, and this is again coming back to what is a pandemic, what is an emergency situation. And I think the old way of looking into humanitarian responses was to look at the choleras, the infectious diseases, what could spread, so to say. I think that Peter Maurer, the president of ICRC, was the first to state that more people get their legs amputated because of lack of insulin than landmines. So even in the humanitarian responses, we have to change. And mental health has been now included. So when we have emergency situations in WHO, we deploy people both from the traditional emergency support, but also from mental health. So I think we are on the right path. But of course, the same problem is lack of investment during business as usual, and then an exacerbation of the situation during a pandemic like this. Thank you.
Well, thank you for this very knowledgeable insight. Well, I was really surprised, not surprised, but positively surprised when there was the Global Mental Health Day recently. And I also went into what WHO offered, and they're using a tremendous amount of channels. I mean, for young people, like even TikTok and other channels I hadn't heard of. My son, he was thrilled. He said, I can't believe they're going on TikTok. Anyway, so it's, you know, innovation as well, but also innovation towards the young people. But we know mental health and suicide is a problem also of young people, which is frightening enough. So I fully agree, but of course it's all down to resources. We have 6 minutes left, and I think we can take at least one other question before we have to wrap up this really interesting session. Now, there's a question that I would like to address, maybe Anne first and then Sarah. How can we collaborate with women to ensure that the new technologies like artificial intelligence used now in healthcare does not have a gender bias from the outset? Of course, now through the crisis, new inventions are up in the market and people get more digital and also experience, most likely for the first time, many the digital possibilities that we have. So how can we ensure that right from the outset, there's no major gender divide?
Thank you, Andrea, for that question. I think in a way, in this situation, when it comes to at least some of the projects that we've been involved with partner institutions in other parts of the world, testing out new technologies in hospital include, of course, because the workforce is major dominated by women, that it is actually women who is using these technologies. So the use of, for instance, iPads or mobile phones to set up systems for communicating with patients, for instance. We also have a system that has been quite widely recognized by many different health authorities, called the DHIS2, which was developed at the University of Oslo. And they collect data by using different digital tools And I think in all of that, women are very much in the center for that. So that actually is an opportunity that I think is now playing out also for younger generations of health workers that are then women to get more involved. And I also think, like Bente, that we need the investments in getting the systems in place in times of peace. And what we experience now is not the only one. This is not the last pandemic. So I think we need to think ahead of how we have something called the International Health Regulations, for instance. That is the system for how countries can be prepared for crises like this. And also, it's possible we should look at that from a gender perspective as well, but also to put resources into really putting it into place with all the sister institutions and all the different environments that we as networks are involved with.
Super. Anne, thanks a lot. And Sarah, you have the final word, a short word, please, so that I can wrap up on time. Thank you.
Sure. I think the most important thing that we can do to ensure that digital health and AI and also technology more broadly does not deepen gender inequities is that we can put women at the center of designing those solutions. We can make sure that they're in leadership roles, that they are on boards, and really integrate them at the beginning.
Thank you. Thank you, Sarah. So that was very short, but very succinct. And as you say, let's see that women are in charge and that they also can determine the way maybe they want to have all these innovations. And maybe from a neuroscience perspective, it's really interesting. We know for digital health and for everything to do with digital that women and men, they have preferences. So why not yet again advocating for really putting the woman or the women in charge? Thank you, Sarah. So I've got 1 minute left, and I really would like to use that minute. So we're halfway through the first session of our first Norwegian National Conference with international guests, national and international guests. And let me first of all thank really Sarah Hilware, Benton Mickelson, and Anne Berg for your very wise, insightful words. And the exchange was really very agreeable with you. I felt very comfortable moderating. Also, a big thank you to Rupa, but Rupa will come back ever so often through, I think, Friday. Thank you to the team behind the scene, and thank you for filtering the questions. And that was Joanne and Gabriella, of course. Thank you to Ingeborg for leading all of this. Thank you to Jeanette Magnus, who is the leader of the Center for Global Health Now, for endorsing and supporting all of this. And of course, thank you to the audience. And I really also have to apologize that we could not take all your great questions. For sure, you can also contact our panelists. Through the internet, you will find their contact details. You can also address us so we can channel. But of course, we can never really take all questions, and there have been really great questions. Some of them I had just to leave aside, so apologies for that. And I now would like to hand over really to Candela, who's also been instrumental in the organization of this first National Women in Global Health Norway Conference for the next part of our session 1. Candela, the stage is yours. Thanks a lot.
Thank you, Andrea. Thank you, everyone, and thank you, the panelists, for session 1. That was a fantastic and very inspiring session, I think, with very actionable advice for each of us on how to lead in this response. Welcome to session 2. I'm then going to be your moderator for this session. In this session, it's a little bit different. We will explore career pathways in global health. And I think what I want to do is I want this session to feel a little bit like a fireside chat. I know we're all in our own homes and a bit isolated, but trying to create a little bit more of a cozy space to ask the questions that we have around how do we develop our career. We will be hearing for this very impressive list of panelists who come from different working environments and who are at different stages of their careers. So we'll start with by having a candid discussion with them. And I'll give the word to each panelist for about 6 to 7 minutes. I will very briefly introduce you, and then I'll just give the word to each of you. And then we will break out into smaller groups where you can have a more intimate Q&A with your chosen panelist. You have already been pre-sorted into your breakout rooms based on the answers on your registration form. There might be some slight changes, unfortunately, if some of the rooms get very full, but I'm hoping everybody will be able to be with the speaker that they chose in their registration. Each breakout session has its own facilitator, so you don't need to do anything. Zoom does everything by magic. Just follow instructions that will appear on your screen. And then we will convene after the breakout session. We will reconvene here for the closing words by Sarah Hilwer, who just listened to for the session today. So remember to write down your questions because you'll have time to ask them in our breakout sessions. So without further ado, I want to introduce our panelists one by one and then ask them to speak a little bit about themselves. And just for the panelists, we have 6 to 7 minutes. So please turn on your mics and your cameras when I introduce you. We are going to start with Bernadette Nirmal-Kumar, who is a professor at the Empower School of Health in India and chair of the Global Society on Migration, Ethnicity, Race and Health, as well as co-chair of the Lancet Migration, and a lot of other very impressive things that she will tell you about herself. So welcome, Bernadette, and we're listening to you.
So thank you very much for this opportunity, and thank you for inviting me. I'm at the moment in Kathmandu. So if I disappear, I will switch off my camera so you can hear me even if you can't see me. What I'd like to start off with is a journey that began many years ago in India. I'm originally from New Delhi, and I would just describe my journey as from day one being survival. It's about surviving and how you survive. And one of the things you asked me was whether my trajectory, my career was planned the way I had planned it, and do I see it there now? And it couldn't be more different. So when I was 4 years old, I was going to be a pilot, and I was told very categorically, girls don't become pilots. And I thought, okay, never mind, I will be a doctor. And that's when I decided that I would do medicine. And of course, as you know, I was also frowned upon and said, well, medicine is fairly male dominated. And it was for a very long time in India. And when I graduated and did medicine, if you are a good student and you do well, you're immediately told, yes, you should do medicine, you should do surgery, and preferably surgery. So I started my career in residency in surgery, and it was actually very exciting, doing both, clinical work as well as emergency trauma work, etc., etc. So global health was very, very far away from that. And today, if somebody had told me at that time I would be doing global health, I would have told them, are you kidding? It's not really what I had planned or wanted to do. But things took a very different turn because I ended up working in Africa, and I ended up working for an NGO in Africa. And then at that time, strange events, and I have to say that my experience of where I am today are events that really I did not control, but they were events that more or less I was open to. So I think it's about being open to the events that take place. And so I did work for the UN in Africa, and then subsequently I'm working with an area that is a very important area of global health, which is migration, and also working with NCDs. So it's good to see that Bente is still holding the flag for the NCDs. So what are the things? So no, the career was not planned at all, and it took a very different turn. And then the next question that you wanted me to sort of talk about a little bit is about what are the things in this particular career pathway that I can see were things that I would say, what are the lessons learned during this particular career pathway? And there are, you know, several lessons learned that I don't have the time to go into. But there are two things that actually define a lot of things in my life, not only my career, and it is diversity and variety. So I do like doing different things. And so I work with research, I work with advocacy, I work with policy and teaching. And the advantage of doing all these different things is also that they are interlinked, but it also makes me, it actually is very important because I never tire of things and I'm constantly engaged. And you need that kind of energy to work in global health. You need to have that kind of energy, and you need to have the energy to run a marathon. So working with global health is like running a marathon, especially for me. And having worked in different sectors, I worked for government, I worked for NGO, the UN, academia, in different stages. And I think that having also worked in these different sectors, I've learned so much. And I've learned that even though all these sectors are very different, they are also interconnected. And those interconnections actually happen both in the head and in the mind. And when all these interconnections were happening, I was gaining what I could from every sector I worked in. And so one of the things that I learned, and I still all the time, and again, I have to go back to my childhood. My mother is a teacher, and I would ask her all the time, why this, why that? And she said to me, not every why can be answered. But I think that the quest for knowing more, when I was in North Korea, and I was basically allowed to do field work, and everybody said, how did you manage to get out and do field work? And I said, I told the North Koreans, if you really need the food and if you really want the nutrition data, you must let me ask the right kind of questions. So I would say some of the most important question is to ask the right questions and to look for the solutions, not only the problems, because people are so tired of the identification of problems. So I think you have to, at the same time, as soon as you're discovering a problem, also begin to think how you're going to resolve it. And the other thing is never give up, because it's very easy to be put down. It's very easy to be told you're never going to get anywhere with this. And if you do that, if you listen to that, you can never go forward. So the resources that I missed when I was in the early stage of my career was exactly this. There was no women in global health. It would have been fantastic. There were no real networks. There were no forums, and there were no peer groups. In Norway, we always joke and say the men always went off skiing, and we don't have, you know, women skiing groups as such. We have started a bit maybe, but those are the kind of groups that you need to support. To the early career colleagues here, I would say that it's so exciting to be at the start of a career. It's so exciting when you graduate because you're full of energy and full of beans and you really want to go out there. But a very important thing before you can go out there and before you can embark on anything, you have to know yourself. And very often we don't really know ourselves, and we are often defined by others. And for a lot of women, defined by men who've been there before. So it's about knowing yourself. It's about being open and unafraid to try different things. And it's only then that we can begin to really, achieve the things that we want to achieve. So those are the things that I would advise young people who are looking at how to, it's all about exploration and expanding horizons. I think those are the things I would say. And I've never lived in the same country for more than 5 years at a time. And actually, I did not hold a job, the same job for 5 years, though now I have worked in this field for, I would say, totally public health. I've worked 25 years in public health. And the thing about public health I like is that there's never a dull moment. And there's always something that you can't really find the answer to, you can't really solve. And I think that's a very big driving force for me. I think the thing that it might sound that everything is all rosy and hunky-dory and, this has been easy peasy, quite the opposite. And the reason is, well, for us who work with public health, and particularly, in public health leadership, We're very excited by what we're doing. We're very engaged. We're deeply committed. But the leaders are not. I mean, very often you can't get leaders, and I'm talking about leaders in countries, to take note of public health. And I think COVID has been a very good example of that, that, suddenly you realize how fragile systems are because public health was never prioritized. So on the one hand, it's a great moment for public health to have that. On the other hand, it really has unmasked, excuse the pun, the problems that are related to public health. So I think that from when I look back, and I look back and see what would have been really useful for me in the early part of my career, it would have been to have the digital kind of technology connections, networks that we have today, the innovation. And of course, at that time, everything in India, at least, was very, I would say, very old fashioned, very traditional. And now the young people embarking on different career paths have the possibility to actually both think and choose out of the box. So I think I've probably used up my 6 or 7 minutes, and I'd like to say once again that I'm really delighted to be here and be able to join all of you. And thank you so much for giving me this opportunity to share. I don't really like to talk about myself, so this is actually quite hard, which is also, I think, a very sort of woman thing, that you really don't like to talk about yourself and what you've done. You'd rather talk about work. So it was a bit challenging to do that. So thank you very much, Candela, and thank you everybody for listening.
Thank you so much, Bernadette, for that very candid storytelling. And I think I will definitely remember this phrase: working with global health is like running a marathon. But also, I think we should all take note of your recommendation. You know, we now have all these amazing networks where we can connect and we can step up. So let's use them. Thank you so much, Bernadette. I'm sure there'll be a lot of questions for you in the breakout session. I now want to introduce Anine Kongel, who is a very dear colleague of mine. I met Anine when she was working at the Norwegian Red Cross, and she's now an EPIET fellow working at the Public Health Agency of Sweden. So welcome, Anine, and please tell us a little bit about yourself.
Hi, Candela, and hi, everyone. Firstly, thank you so much for having me. I must admit that it was a bit daunting as well to be asked to be sharing about my career, especially because I still consider myself quite new to the field of global health, even though when I was thinking about it, preparing for this session, it's actually been about 10 years now. So maybe I'm just resisting to grow older. As Candela said, most of my career I've spent with the Norwegian Red Cross, and lastly as the team lead for the public health and community-based surveillance team, working on epidemic and pandemic response. But I've just started a leave of absence from the Red Cross to pursue a fellowship with the European Centre for Disease Control. And so I'm calling you in from Stockholm. Bit about my background. So I graduated nearly 10 years ago from the London School of Hygiene and Tropical Medicine. And I have quite a mixed academic background stemming from the humanities and the social science path. My bachelor's is in international development studies with a bit of social anthropology and Arabic. So I kind of came out of university not really knowing what I knew. And I think that led me to apply for quite a specialist master's program. I was really engaged with HIV at the time. And so I embarked on an MSc in reproductive and sexual health research, which seemed to kind of fit my interests. And that was also quite daunting because almost all of my colleagues at the London School was a medical doctor or a microbiologist. And there I came with my social science hat. So following my master's, I dabbled with research for a couple of years. And then I was kind of taken by a sense of impatience, and that impatience with the research and how long everything took led to a bit of frustration. And I realized I wanted to be more operational, and I wanted to be closer to kind of the action of public health and closer to the impact and how ideally how research and evidence can inform that impact, but really to be more on the ground. So I applied for the Red Cross emergency roster, and very soon after that I went on missions to Haiti and Sierra Leone, and Ebola happened, and I got pulled into the epidemics work. Within the Red Cross, I've been contributing to building the public health emergency response portfolio, and also advocating and working hard to make Norwegian Red Cross specializing in surveillance and particularly community-based surveillance. And it's been really rewarding to be able to forge partnerships between the humanitarian sector and the technology industry, and actually building tools that can have a real impact on epidemic preparedness and response. And just to make a kind of a short comparison between the research side and the humanitarian side, I think I really enjoyed doing the research. It's fantastic when you have the funding and you have a strong team and you can really deep dive into your topics of interest. But it can also, or it was for me at least, quite lonely, quite frustrating, and quite stressful, always having to chase funding. And then the main issue was really realizing that, you spend 2 years really exploring HIV prevention among sex workers, and the process and getting the results are taking so long that when they're finally ready, and not even to mention having it published, it's already a bit outdated. The program has already moved on. So what are you impacting? So it became a bit tricky for me to be so distant from the actual humanitarian impact. But then at the same time, on the humanitarian side, especially working for such a large organization like the Red Cross, you can get so pulled up with bureaucracy and internal processes and politics even, and you get quite far away from driving the evidence agenda and contributing to generating that evidence from the programs that you're involved in. And then just lastly, the biggest challenge for me, I think professionally, has been when talking about women in leadership and coming from a technical field of public health, needing to kind of choose between the leadership managerial path, moving kind of upwards in the hierarchy, taking on more responsibilities and leadership roles, without losing your grounding in your technical specialization and continuous development within your field. So I found for me that I needed to take a step back at this point in time of my career and focus on my continued professional development and technical training within field epidemiology. And so hopefully I can figure out later on how to combine the two.
Thank you so much, Anina. I think that's, I think what you're saying probably resonates with many of us in working in global health. At least it does with me, the pull between research and being on the ground, being more operational, and also, this impatience both with how slow research can be, but also, having to deal with bureaucracy on the other hand when you work for bigger organizations. We still have a little bit of time left for your intervention. Could you told us a little bit about the things that, were hard for you both in research and working in an NGO. What are the things that you've loved the most?
Great question. I think within the humanitarian side it's being really seeing the impact that your programs can have, and working with your colleagues in the field, with the volunteers who are actually conducting the work, and then having that space to collaborate with partners, both within the humanitarian side, but also, as I mentioned, within the technology industry, and actually finding the solutions. I really appreciated Bernadette's comments about it both being public health being a marathon, global health being a marathon, but also how solution oriented you need to be. There are so many problems, and I think if you want to carve out a career in public health or global health, you really need to contribute to finding the solutions, and not theoretical solutions, but practical solutions, and actually put in the time and the work it takes. And I found that within the Red Cross, I was really able to contribute to some of that. And it's just incredibly rewarding to see that come to life.
Thanks so much, Anina, and I'm sure people will have a lot of questions for you. Just as a reminder, in the first panel, we also touched upon the role of women, especially in the digital health area. So this is definitely an area that you can explore with Anina, because she's been working on that. So probably lots of questions for you in the breakout session. Great. I now have the pleasure of introducing Bernadette Abella Ritter, who is team leader for neglected zoonotic diseases at the World Health Organization. And I'm sure she'll tell us a lot more about her career. So welcome, Bernadette, and the floor is yours.
Thank you very much. It's a great pleasure to be on this webinar, and it's actually humbling to be invited to this. A lot of the issues that have been brought up already resonate, so I don't want to repeat things, but there will be some overlap, I think, as we progress through careers. There will be overlap, but what I'd like to start off with is something really that I go back to quite often. I grew up in a family of 4 girls, no boys, in a rather conservative sort of setting. And my father would always say, you will all go to university, you need to study, go to university so that when you are adults, you will be independent, you can run a family even if there's no male in the household, and you can sustain yourself and your family. And I think that was already the seed of where myself and all my sisters actually was set already at that time. And we left our home country and went to Kenya, where in the 80s there was a lot of poverty, a very, the semi-urban areas were really impressive for someone coming from Europe. And so I think already at that time, I also started to realize that development was so important, education was so important, health was so important, but I loved animals. And so putting that all together, I'm a vet by background, a little bit different probably from most of you here. And I did not directly go into the area of public health immediately. I had this romantic idea of becoming a horse vet, and then started my PhD on equine medicine, which in the middle of it, I did complete it, but I knew my heart was somewhere else, and it was in tropical medicine and in epidemiology. So I then sort of midway started a master's in Edinburgh and completed the tropical veterinary degree, which had this sort of public health angle as well. So it was not a direct fit, but I think in the meantime, and this is what I tell young students or young people who are on the threshold of their career, just finishing fresh, ready to go, all energy, wanting to change the world like we all want. And I always tell them, and as I tell my children, find something that you're passionate about, because that is what will drive you. That's your battery. That will give you the energy and the perseverance to get, through any almost insolvable problems, just because you are driven from the core rather than just from generating money or whatever. So that's really what drives me as well, is my passion, is the want to make a better world for people. And I work now in the neglected tropical disease department in the World Health Organization. It's something I've been in the WHO for 13 years. I love working on the subject. It's really the nexus of development and health. animals and humans, how we interface with each other. And so it's the work I lead is really around the zoonotic diseases and their impact on human health. And I don't lead the work on the diseases that hit the headlines, but more on the endemic diseases that are really very, when we're talking about equity, here is something where we are targeting the most disenfranchised populations, and that's really something that I'm passionate about. So I lead the work on rabies, on the pig tapeworm Bacteria solium that causes epilepsy in highly endemic areas. Of more than 40% of epilepsy is caused by that. I mean, in these highly endemic areas. So these are diseases that you can hardly pronounce the name. There's not a lot of political interest, but we are building that as we move forward. One of the questions that was put was a part of what I should be answering is, do you multitask? Oh my goodness, I think women carry the world, and we do so many things at the same time, not only technical, but we're there emotionally for many of the subjects that others might not approach. We're there for our families, for the kids. For example, my husband is in China over many, many months. I've got the kids to take care of, but we're running, the family, the work. And I think that's part of the motivation, the energy that comes from that. I get energy from multitasking, and I enjoy the versatility. And now I'm going back to my work side. I like in the multitasking, I'm covering very diverse diseases, multiple animals, So what I like is the versatility. I love to grow and to develop. I think there are many drivers around the world that impact health, and we see that with COVID. We've just talked about it. The wonderful speakers in the beginning have touched on all of that. COVID is a virus, but it has impacted many, many parts of not only the health system, but much broader. And so the broad understanding of how issues interlink in such a complex environment is something that, I would like to understand better. We don't always have the answers, but we can inch by inch do and learn and make progress. And so a lot of my work is working across the sectors. Of course, as you heard, I'm a vet. Not always easy in a public health organization, especially when you're timid and you come in all new, what's a vet doing here? But, and as the other Bernadette said, it's not always hunky-dory, right? It's sometimes difficult, but you have to sort of learn to stand up for yourself and be less meek. But it is a wonderful place to be exposed to the diversity of expertise and knowledge, which I'm still in awe of, even now after 13 years at the organization. So there's a lot of multi-sectoral, we deal with not only the public health agencies, but we deal with pharma who provide us with tools. We deal with the non-governmental organizations who help us increase our reach, especially in the work I do, where there's not a lot of interest. We have, the non-governmental organization increasing our reach into the areas where the road stops and life of people in the rural areas begins. And so it is a really rich environment. It's a place where one needs to provide leadership, sometimes negotiation, because we don't all have the same priority setting. So I love working with those diverse sectors, and I think it's challenging, and it needs leadership. And I think one of the things that women in general could benefit from is trying to nurture the leadership skills to be more upfront, less timid about asking questions, being a little bit more out there. And I think as the previous speaker said, it's not always easy. So going on to the other questions, what have I learned from my career path? You know, I've always been interested in development and health, health of humans, health of animals, their interconnection. But life takes you on a journey, and you start off with the opportunities that are laid before you. And you know, sometimes it's not the ideal, but it's a stepping stone which takes you to that next place, which you know, opens up a new world of discovery. And I've moved jobs now. I'm in Geneva for 13 years, as long as ever. But you know, moving from different places, working in the field in research, working in the clinic as a vet, you know, working in Cameroon as a project manager, and you know, a very diverse background. And I think there will be more time to discuss in the breakout session, but as the others said, I think one of the most important resources is trying to match up with a mentor to sort of bounce off ideas. I think there's a great opportunity for information. In fact, there's information overload all over on the internet. But I think a human interaction is always a wonderful place to start in order to help guide your career path. Thank you.
Thank you so much, Bernadette. This is really fascinating. I love the passion, and I love how you actually managed to use your vet diploma, your vet skills, now working with animals. So there's always this possibilities of interconnection. And I really want to highlight the last point you made about how important it is to have a mentor. So I think that's very, for all of us at every stage of our career. And I'm sure people will want to ask more questions about this in your breakout session. Thanks so much for that. And now I have the pleasure of introducing Benedict Louise Alvarez, who is the Senior Advisor at the Department of Global Health at the Norwegian Institute of Public Health. So welcome, Benedict, and we're happy to hear your story.
Okay, thank you. Can you see me well? Yeah? Yeah, okay, excellent. Thank you so much. Well, and thank you, Candela, for inviting me here to the Women in Global Health Norway for this to participate in this great initiative. And I've been really appreciating listening to my Anne Berg, with whom I work at the Graduate Institute, but also at the Norwegian Institute of Public Health, but also with Benton Mickelson, with whom I worked 10 years ago when I was in the Ministry of Health in Norway, coming back from Switzerland before Benton was going back to Geneva. So in my presentation, I have about 4 points, and I will try to stick within those 6 minutes. I want to start about why and how I ended up in global health. I'm born in Norway, but I traveled to Switzerland to do my studies in political science, and I graduated from University of Lausanne. Having been so close to Geneva and the diplomatic community, I wanted to pursue a career in international relations and in diplomacy. And in 2000, I was introduced to global health for the first time. I accepted an offer for an internship to the United Nations System Staff College in Turin, Italy, where Kofi Annan had just established a program trying to increase partnerships between the UN and the private sector. And for 3 months, I was working on a project where we were evaluating the global polio eradication program. And from there, I was hooked on global health. And I was determined that I was going to go to Geneva. And I started a 2-year master degree at the Development Studies, which is now the Graduate Institute of Public Health, the Graduate Institute in Geneva. And I was writing a master thesis on public-private partnerships. And I was using the case of the Global Fund of to fight AIDS, tuberculosis, and malaria as a case, as this was a totally new happening, that the public sector and the private sector were jointly working together. And when we look back, this was also a trend that actually changed around the year 2000. So in 2002, I started actually working in the World Health Organization on a short-term contract in the strategy unit of the Director General's office, where I was working on international trade and health. I didn't have a lot of experience in the trade field, as I was more a political scientist and development from a development side background, but I was working with key people on governance issues. And basically what we were doing is what WHO is actually doing today, is to develop, to strengthen capacities within ministries of health in the country level, so that they have the best evidence-based when they go into negotiations on the country level. And we knew from the time many countries were struggling, where they were their countries and finance minister were going into trade agreements, bilateral and in WTO, and health was not taken into consideration. So we were there working on analysis and research, creating tools that countries could use, and we were also meeting requests for country support. And from there, I was totally hooked on global health, and I still am. And that leads me sort of to the second point of my talk that I want to talk about, is the how to use the different experiences in your career into the path of global health. As I said, I never went to the field and the country in the low resource setting to work. My field in a way was Geneva. And I learned very quickly that there is a big political context within one is working and operating. And it was very learning for me as a young junior to work within this context. But then when I went back to Norway, I stayed 7 years in the World Health Organization. But in 2009, I moved back to Norway, and I was starting working also with the Minister of Health level in Norway, and where the main focus there was to look upon international health and global health, but more from the national perspective. And I realized that I could actually use those tools, having worked in the in Geneva and WHO. You were using the same as on the national level of a country like Norway, because Norway was a national actor, of course, on health and global health, but also the Ministry of Foreign Affairs and NORAD. So I was trying to see that was very useful for me to use both those experiences into how I was also developing my own career within Norway, but also to combine those two. And then in 2013, I came to where I still am now, is the Norwegian Institute of Public Health, where I'm leading a team on global governance and policy issues. And again, it is all based on the same, that we're working to try to provide best knowledge base for good decision making. This leads me then to my third point, which is maybe more personal, which I think is very important. And starting with what I wished I'd known being early in my career. First, I wish I had worked harder on how to prioritize. People said it around me, and especially I had many male friends, and they were prioritizing all the way. And I was like, what's this? And they talked about it, but I didn't try to implement it. And I must admit, it was only until I had those 2 children that I have now that I learned how to prioritize and how important it is. So I would just tell you guys, learn how to prioritize it. And the second of all that I learned is that we want to deliver good. We want to deliver the best standards we can. And many of us, and that is linked to the first point, is going for the gold standard all the time. Sometimes that's not possible. And you know what? The rest of the world, the other sex, they are very often going for silver and bronze standards. And I think we as women, we should always sometimes be comfortable by doing that. Sometimes it's good enough. And then the third one, I just want to say that the most of the worries I actually had never materialized. I was worrying for things that I thought would happen, what if, and it didn't happen. And I have been learning, and I still do, how to deal with that. But I think that is not, it is important to do, I think for me, it has been very important if I knew that when I was younger. So if I wrap up with my last point, I mean, my advice to the young people is that we've heard it now. Get yourself a mentor, even several. Get practical experience. Sometimes you get a job which may not be very interesting. But for example, if you get the job, always be the one who takes the minute from the meetings you are at, because you will know how to shape. If you want to be in shaping and managing the global health policy environment, being in where you are able to sort of be the one who's sitting with the pen could be a huge possibility. So I would say go for that. And be curious and ask questions. In this world today, one might say that there is a lot of polarization. It is often those with extreme voices who dare to speak up. I would say that for those of us who consider ourselves as in a more maybe, I could say more normal, but we need also to dare to speak up. We need to stick our head up and reach out. And a very smart senior person I met once, he said, engage in outreach and network. And that is very important for us to take up now forward. And I must just say, it is a wonderful world out there and wonderful people, and seek out and join this global movement as now the Women in Global Health is. So with that, thank you very much.
Thank you so much, Benedict. And while you were speaking, I was just nodding my head because, you know, all of these things that you're saying about, you know, how we go for the gold standard and then how we worry about 10,000 things that never materialize, that resonates a lot with me. And I'm sure it resonates a lot with other of our participants. So I'm sure there'll be more questions to you on that. And I also very much liked this idea that you bring up that, you know, your field has always been NIVA, so there's always space in global health to work in different places in the world and in different areas, and it's just not just only working from low and middle income countries, I would say. So thank you very much for bringing that up. Great. We are reaching our last panelist. So Fiola Sigurdardóttir, who is the founder of Prelude AS. And I was talking to her a few days ago, and she has a really interesting story because she comes from the startup world. So it's a completely different perspective that she brings into this conversation. So welcome, Fiola, and the floor is yours.
Thank you so much, and thank you for inviting me for this session. And I have to agree with Anina that I still feel that I actually feel that I'm in the infancy of my career, especially when hearing from so incredibly experienced speakers. So I'm honored to be able to be part of this. My name is Fiola Sigurdardóttir, and I'm a medical doctor, and I graduated from the University of Iceland. And although I did know from a very, very young age that I wanted to become a medical doctor, I didn't believe that my medical education would be so colored by another crisis that we experienced in 2008. So not COVID, but the financial crisis. And that really stuck with me because I didn't believe when I started studying medicine that actually finance and financial systems would have so big impact on population health and how we provide care and the care that we are able to provide for our patients. So that has really stuck with me ever since and probably influenced my choices in some way. After graduating, I first went a very traditional path, and well, I moved to Norway, which was maybe a bit untraditional at that exact point, but I did my internship at the Akershus University Hospital here in the Oslo region. And then in 2017, I did an untraditional move, and I started a company called Prelude AS. I've also completed a program called Clinical Effectiveness in Boston at Harvard School of Public Health. And that program really focuses on implementing effectively the newest evidence in medicine to medical practice. And there I met a lot of like-minded people who were also maybe even founders or researchers, and that had a really, really good motivational impact on me. I'm also currently writing my PhD in cardiovascular medicine with a focus on sleep disorders and cardiovascular health. And I guess I've thereby answered the question of whether I do many things at the same time. But the main input I wanted to bring to this discussion is based on my startup, Prelude AS, and on how there's a big opportunity for innovation and technology in the global health response. I started Prelude because I saw a gap in the continuity of care being provided in Norway, Iceland, and other countries. And I just couldn't stop thinking about how existing technology could be used in different ways, and most importantly, to make our care better. I had founded small NGOs in Iceland, and I had solved problems related to the financing of vaccination for the healthcare students in the academic setting at the University of Iceland. And I somehow thought that starting a startup would be way quicker and easier in terms of problem solving than the bureaucracy within NGOs and academic institutions. There was and there has been less bureaucracy, no doubt, but there's definitely many different challenges in starting your own company and especially within the tech sphere in these days. However, I just wanted to highlight that I've learned a lot that I probably would not have learned just being in my traditional field. And I would be happy to share any of that with anyone who's interested. But the main point is that I'm convinced that there are many ways to use technology to improve our population health. And it is incredibly important with female entrepreneurs, not only female leaders in health tech companies, but also female ownership. And I'll come back to that in our discussion group, why I believe that is so important. But as Sarah Hillower mentioned, women tend to focus more on vulnerable groups for some reasons, but that is important to balance the inequalities that we're already seeing on the rise. Even despite the good work that's been done in the past couple of decades, we suddenly see, even in Iceland, gender equality, like there are some indications that young people today have different views than I would have believed that they had now, coming from my background and my upbringing. And there's also, there have been some serious bias cases in terms of AI in the algorithms that have been produced for example, in the US by some companies. So it's incredibly important with female entrepreneurship, female ownership, and that we are aware of all of these inequalities and these different factors that women maybe are more aware of because we experience them and we've felt them on our own skin, so that we can actually incorporate that from the get-go. And just remember that so many fantastic solutions in our society have actually just started as a simple idea, and we really need to kind of embrace that both in the private sector and the public sector, and that there's an opportunity there to lead positive change, quite literally. The lessons I've learned are have kind of been highlighted on already now, is that it's important to find role models and mentors, and just reach for the opportunities and the ideas that you have. I think the time is now. And as Benedict said, I mean, it's a great point with the prioritization and also the standards, like try to do things like well and good, but it doesn't need to be perfect. And I would like to add on that not only do your job the best as you can, but also create your own job. Don't be dependent on someone else promoting you or giving you the opportunity. Create it. So yeah, I guess because we're running a little bit late on time, I'll stop there, and then we'll take some more discussions in the groups. Thank you so much.
Thank you so much, Yela. And it's so inspiring to have someone first so young and already having started their own company and so on. And I really appreciate that we have been able to bring this voice that we don't necessarily usually hear about when we are talking about career pathways in global health. So thank you very much for that. And I'm sure there's going to be a lively discussion in our breakout room because I'm moderating yours. Thank you, everyone. Thank you to all the speakers. These were really powerful and inspiring stories. What I take out from this is that, global health welcomes everybody. You all come from different sectors, NGOs, academia, multilateral organizations, the private sector, and you all come from very different backgrounds, from medical doctors to social studies, international studies, international development, veterinary sciences. There's a space for everybody in global health, and I think that's really wonderful. So I think we're now going to go into our breakout sessions. You'll get a message from Zoom, so just follow the instructions on your screen, and we'll reconvene here with 5 minutes before the end to hear our parting words for the day from Sarah Hillower.
Before I give the word to Sarah, who we met earlier today, let me thank this year's organizing committee. This conference is the result of fantastic teamwork with a group of impressive ladies, and you've met some, and some are in the back room, and some you will meet later. Candela Iglesias. She's the founder and director of Global Health Advisors. Just met her in the previous session. Joanne Fielding, market development and Project Health Manager at Global Health Advisors. She's one of two jewels in the back office. Eva Turk, Senior Researcher at UIO and Associate Professor at University of Southeastern Norway. Eva, you will meet, you've also met her in the breakout session, and you'll meet her on Friday. And Sarah Osmond, founder of Osmond Advisory Services. Sarah has also been facilitating one of the breakout groups here. So in addition to these fantastic four ladies that I've been so fortunate to get to know and work with these last 6 months, we have my great and fantastic colleague in the Secretariat, Gabriela Rodriguez. So a warm thanks to all of you. So now I'm looking forward to your final remarks, Sarah, for you to close it. I hope you all enjoyed our conference. Stay tuned for a few more minutes with Sarah, and welcome back on Friday.
Great, thanks so much, Ingeborg. And it's been so great to be here with all of you, distinguished speakers and guests. It's been truly a pleasure, and sincere thanks to WGH Norway for having me and for organizing such an inspiring day. And congratulations to the Secretariat. So to close our discussion, I'd like to make 4 key points on gender equity in health. And the first point is to put the last first. 2 is pay unpaid women. 3, gender equality is for all. And 4, support women's movements. So first, put the last women first. So to achieve true health for all, we must put the most marginalized at the center of all policies, programs, and most importantly, budgets, because this benefits everyone. And this means making space for girls and women to lead on designing solutions at all levels, especially from those from LMICs and underrepresented groups, and standing firm to prioritize women health workers, especially those in low-paid, low-status roles who deliver on critical health services, especially life-saving SRHR and maternal and child health services, vaccine distribution, and more. The second point I'd like to make is to pay unpaid women. We must stop allowing systems across all sectors, especially health, to be subsidized by the poorest women and girls. In particular, women health workers contribute an estimated $3 trillion to our gross world product, of nearly which half is unpaid. More broadly, women and girls perform 75% of all household and unpaid care work. So it's absolutely critical to bring both women's unpaid work in health and social care into the formal labor market where appropriate, and to work to change norms to redistribute unpaid household and family care equally between men and women. 3, gender equality is for all. So we must prioritize gender equality and recognize that it's everyone's business. A more gender equal world benefits everybody. In the case of COVID-19, men have worse health outcomes, which is higher mortality from COVID-19. And in almost all countries, it's been noted that women political leaders are doing far better than their male counterparts in responding to the pandemic. Yet it's not because women are born with an empathetic gene or with bigger ears that make them better listeners. Evidence shows that many female leaders practice a style of leadership that's less individualistic, more inclusive, and more effective in building public trust. Everyone can do this, men included. 4, support women's movements. And this one is my favorite because it really does support these other asks, these other points that I've made. Strong women's movements in health, in climate change, even we've seen women leading, especially young women, front and center. So we need to continue to support women's movements. And right now, less than 1% of all aid in gender equality actually goes to women's movements and organizations. So we need to ensure that women's organizations and especially grassroots movements who are really making these changes and really leading from the ground up, like Women in Global Health chapters, are supported and are provided with resources to be able to continue doing that critical advocacy and movement building work. So with that, I'd like to turn it back to the Secretariat, and thank you all so much for having me today. I hope that you'll all continue to stay engaged with the WGH Norway chapter. And if you're not located in Norway, I hope that you'll visit our website, womeningh.org to learn how to either get involved in a chapter or start one where you are. Thank you.
So with that, thank you so much, Sarah. That was really nicely wrapped up. So I'm going to leave you all. I hope to see you on Friday. Have a very nice Wednesday evening or afternoon or morning, wherever you are. Bye-bye.